All right, let's get right into it. For over 2 centuries, the stethoscope has been this iconic symbol of medicine. But in the trenches of the ER and the ICU, where things happen fast, a new tool is completely changing the game. We're talking about bedside ultrasound, and we're going to dig into how it's revolutionizing patient care using the Manual of Emergency and Critical Care Ultrasound as our guide.
And that quote, it just hits the nail on the head, doesn't it? This isn't just another gadget for getting clearer images. We're talking about a massive upgrade to our clinical skills, right there, at the bedside, when every single second is critical. It's all about making safer, faster, and just plain better decisions for our patients.
So here's our game plan for this explainer. We'll kick things off with how ultrasound is shaking things up at the bedside. Then we'll cover its absolute cornerstone application in trauma, the FAST exam. After that, we'll see how it helps us answer life-or-death cardiac questions, and then look at the protocols for shock. And we'll wrap up by thinking about what this all means for the future of the physical exam itself.
Okay, first up, let's really set the scene here. In any critical care setting, the biggest challenge is always the same. You have to make huge decisions with, let's be honest, incomplete information.
I mean, think about that patient who's crashing right in front of you. Are their lungs filling with fluid? Is their heart even pumping effectively? Is there a hidden bleed somewhere? A few years ago, getting answers meant a risky trip to the CT scanner or a long wait for a formal study. Now, bedside ultrasound cuts through that dangerous uncertainty in seconds. It's not just imaging, it's a direct extension of our hands and our ears.
Now let's focus on the one application that really put ultrasound on the map in emergency medicine, and that, of course, is trauma.
Picture the scene. The trauma bay is chaos, right? You've got all these obvious injuries you're dealing with, but what's the one thing that can kill the patient that you can't see?
Yep, internal hemorrhage. A patient can literally bleed to death inside their own body without a single drop of blood on the outside, not until it's way too late. Finding that bleeding fast, well, that's often the difference between a patient living and a patient dying.
And this is the tool built specifically for that problem, the FAST exam. We're not looking for subtle anatomy here. It boils down to a very simple yes or no question. Is there free fluid, which in trauma means blood, where it shouldn't be? We're talking around the heart, in the chest, or in the abdomen. It's fast, you can do it over and over, and you never have to leave the patient's side.
And you can see here, this wasn't some overnight fad. It took decades to catch on. It starts out in Europe in the 70s, then by '88, it's a required skill in Germany. The real tipping point, though, was in '97, when it got integrated into the ATLS course. And by 2001, it was so vital that every EM resident in the US had to know how to do it. It had officially become the standard of care.
But the story doesn't end with trauma. Far from it. Because clinicians started thinking, hey, if we can look for fluid around the heart in a trauma patient, why can't we use it to answer other critical questions in our medical patients? And that's the key. A bedside echo isn't meant to be a full-blown cardiology study. It's about answering very specific, incredibly high-yield questions. 1. Is there a pericardial effusion causing tamponade? And 2. In a cardiac arrest, is there any cardiac motion at all? That simple look can tell you if you're dealing with true asystole or just fine VFib, and that totally changes your next move. Simple questions, but with absolutely profound consequences.
This image is a perfect example of how powerful this is. We're looking at a parasternal short-axis view. See how the left ventricle is supposed to be a circle, but it's getting squished into a D shape? That's because the right ventricle is under massive pressure, flattening the septum. That's the classic sign of a huge pulmonary embolism. Finding that in seconds, well, that's a game changer for your patient.
So it was a natural evolution. We went from answering single questions about one organ to combining all these skills into systematic protocols. And this is for evaluating our sickest patients, the ones in undifferentiated shock. And this is a massive leap. Instead of just guessing what's causing a patient's hypotension, is it the heart? Are they volume down? Is something obstructed? We can now do a quick, systematic scan of the whole system to hunt down the cause.
And that's led to these really clever protocols, like the rush exam. The mnemonic just makes so much sense. You evaluate the pump, the tank, and the pipes. You've got others too, like ACEs and CAUS. They all give you a mental framework to rapidly check for the big, bad causes of shock, whether it's heart failure, a ruptured aorta, or a PE.
And it doesn't even stop with diagnosis. Ultrasound has totally transformed how we do procedures. The old way, using landmarks, was basically working blind. You'd feel for a pulse, aim for a spot, and hope. With ultrasound, you see everything in real time.
You see the needle, you see the vessel, you see the nerve next to it. It has just skyrocketed the first-pass success rate, and more importantly, it's made these procedures so much safer for patients. It's quickly becoming the only acceptable way to do it.
So, when you put it all together, trauma, cardiac, shock, procedures, what does it all mean? Where are we headed? Look, the bottom line is this. Point-of-care ultrasound isn't some cool new toy anymore. It's a core competency. It's an absolutely essential skill for anyone who takes care of critically ill patients. It makes us better diagnosticians, it makes our procedures safer, and it helps us take better care of people. It's that simple.
Which brings us right back to that question we started with. Is ultrasound the new stethoscope? You know, maybe a better question to ask ourselves is this. In a time when we can literally see what's happening inside our patient's body right at the bedside, what's the future for a tool that only lets us listen? And that's something we all have to think about.